Right. Again, good afternoon, everyone, and thank you for joining today's session. My name is Casey, and on behalf of the PRRP Exchange team, we're excited to have you join today's session and take part in a discussion around pediatric readiness recognition programs. Before we get started with today's session, we would like to acknowledge that the EMSC Innovation and Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. As a cooperative agreement with a federal agency, the EIC must adhere to executive orders and related federal guidance. Currently, EIC-funded staff are unable to engage in activities or discussions on topics that are limited by executive order. We appreciate your understanding and ask all meeting attendees to refrain from discussing any topics of concern defined within executive orders. Additionally, the contents of today's presentation are those of the authors and do not necessarily represent the official views nor endorsement by HRSA, HHS, or the U.S. government. As a reminder, here we have our goals for participating in the PRRP exchange. These come from the goals shared through our exchange survey a couple months ago. Our goals are to collaborate and hear from others implementing recognition programs, to collect resources to support recognition programs, and to identify and address barriers related to recognition programs. So during today's session, we do ask that you turn your camera on if you're able to, share your experiences and ask questions of one another. I did want to see if before we got started today with today's topic for discussion, if we wanted to follow up on a question that Rachel Ford had brought forward during our July session, wondering how pediatric readiness recognition programs differ from the ACEP ED accreditation program. If that's all right with you, Kate, to share?
Yeah, absolutely.
On that? All right.
Happy to.
Let me switch slides here.
So as you're doing that, I'll just start by talking. So as many of you know, ACEP now for about a year has been working on establishing an ED accreditation program. There was a lot of confusion around this program from the very get-go, I think because, well, in part, the initial term or acronym that was being used was EDAP, which was really intended to be ED accreditation program. But as many of you know, EDAP is also a term that's used in our world around pediatric readiness. It was used in California with the creation of the EDAPs. ED is approved for pediatrics, and also used in Illinois. ED is approved for pediatrics. But that was not at all the intent of the ACEP accreditation program. They just were using that acronym initially because of that. Shortly thereafter, we had given a little bit of feedback to the American College of Emergency Physicians and suggested that they might consider changing the name of that. Fortunately, with Marion Gaucher-Hill at the helm of leading this task force, they were able to reconsider and have since changed the acronym for this to be ED Accreditation Program, EDAC. So EDAC as an ED accreditation. So you all will start to see this as kind of a new term, but that might be some of the background for this. So just based on Rachel's initial question, we thought that we would present to all of you a little bit about what this program looks like and the overlap that might exist with pediatric readiness. The one thing that I do want to just share up front for clarity as kind of a summary statement around this is that this is not intended to take over or take the place of a pediatric readiness recognition program in your state or territory. Similar to what the American College of Surgeons Committee on Trauma has done with their verification standards, as a leading organization within this effort, within the National Pediatric Readiness Project, there's this balance of wanting to support the Peds Ready efforts, but not to take it over single-handedly. And so what you'll notice is that they are inclusive of pediatric readiness, but again, not nearly at the level of pediatric recognition programs. This is very similar to what the ACS standards are. So the American College of Surgeons Committee on Trauma Standards for the ACS verified trauma centers is that they must take the Peds Ready assessment, address any gaps, and then submit those gaps to the review or site review committee, and then they can be accredited or verified as a trauma center. That is very similar to what this is as well. Okay, so The goal of the ASAP accreditation program, though, was really to focus on elevating hospital emergency departments who are ready to provide care for all patients, but certainly with a little bit more of a focus on adult patients more broadly. Um, Part of the background for this and why the American College of Emergency Physicians decided to do this is that as many as up to 40% of patients who come through the ED and end up as inpatients, and up to 70% of ICU patients actually come through the emergency department. So this is a critical access point for the majority of patients, and this is really looking at it primarily from the lens of adults. And as you all know, most patients don't have a lot of choices when it comes to EDs. They go to the place that's closest to them, and they felt that accreditation was a way of elevating the facility's resources and approach to caring for the emergency patient. So you can go to the next slide. So the ASAP program has really focused on EM board certification. This is not PEDS emergency board certification. This is emergency medicine board certification. However, you all will note that in the most recent 2021 PRRP assessment, there was a question asking about board certification. And what we have found in analysis is that those EDs that have either an EM or a PDM board certified physician are more likely to have higher pediatric readiness scores. Now, it might surprise you to learn that what we also found is that about 90% of all emergency departments in the country have at least one EM board certified or PIM board certified physician. So this is not a rarity. We do have a lot of board certified emergency physicians working in the emergency setting across nearly every hospital in the country. And then the focus being really on ensuring the environment similar to pediatric readiness, but focused on the environment both for adults and peds, includes all of these domains of particular interest. Disaster planning, psychiatric emergencies, which is a huge issue on the adult side, certainly staff safety and issues related to violence, and then pediatric safety related to medications and overall readiness. So next slide. What they're hoping is that this will bring value to patients. It'll be meaningful for physicians because it'll help them to work in an environment that's ready to care for patients, and it'll bring value to hospitals, really in large part from the financial lens of saying we're here to provide value-based care, high-quality care to patients in our community. Next slide. So these are their accreditation criteria. They are not specific to pediatrics. So I know I have to keep saying this, but I just want to be very clear. So it's about general physician staffing. It's about general physician contracting. It's about other staff. It is about integrating a quality improvement program, having policies in place, and having resources. But you will note, yet again, I'm just going to keep reiterating this so everybody is aware that ASAP, as a leading partner of pediatric readiness, couldn't develop an accreditation program and include nothing related to pediatrics. That would be, frankly, I think almost negligent based on where we are now. So they had to include components of pediatric readiness, but they did not want to go alone as being the only entity developing pediatric readiness programs. So much of this has lived within EMSE. It's lived in a agnostic environment where it's not about money driving, pediatric recognition. It's about doing the right thing for kids. And in order to do that, so much of the momentum of the program has been all of the organizations joining forces and coming together. Next slide. So there are 4 levels, I guess, for the recognition. There's gold, silver, bronze, and then there's this federally designated rural or emergency hospital accreditation level, which is really intended for those that are lower resource, that have difficulty with access to all staff, and that's really the blue ribbon recognition. Next slide. So levels 1, 2, 3, what do they require? They require ABIM certification or AB the College of Osteopathic Medicine, AOBEM, board certification, and or PIM physicians. In most cases, I would say in 90% of these cases, it's going to be ABEM, it's going to be general emergency medicine physicians, as opposed to PIM, just because of what we know. I think currently in the country, there's less than 3,000 pediatric emergency medicine physicians, and there are a lot more board certified general emergency medicine physicians. If you're a rural critical access hospital, they're just requiring a physician on site, physically on site, 24/7, 365. Next slide. So most of the accreditation really relates to physician oversight, including the development of policies, quality, and resources. So we'll go through these really briefly. So all levels, the ED medical director is expected to be board certified in emergency medicine or PIM. They are supposed to be overseen, and a lot of this is around oversight, overseeing the privileges of advanced practice providers in their ED and ongoing practice evaluation of those providers. They're also supposed to ensure that there's a process for looking at why physicians might leave, because they recognize that even in the physician community, there's a high level of turnover of staff. And so really trying to make sure there's understanding around, I guess, the culture of that ED, and that there be some form of direct or indirect supervision of encounters, so that there's kind of this shared responsibility across the entire team, and that there's integration with the trauma team. Okay, and I'm happy if anyone has questions as we go through this, feel free to jump in. Policies. So all levels are expected to have policies that include formal onboarding of staff who come in, like what are the requirements, what are they expected to do with respect to credentialing and the like. There's supposed to be a hospital policy that really identifies the admitting physician as being responsible for care, and to ensure the best outcomes, and of course within the resources that exist. And then in addition, they want policies related to imaging, and notification of outpatient teams. So if there are primary care physicians, so that they can help to integrate care across the group, relative to both imaging but ongoing care. Next slide. This gets at consults, policies around procedural sedation, policies around psychiatric disease, those who are boarded. But you'll notice, and Casey, thank you for highlighting this, that they do require there be a disaster plan. It doesn't specifically call out pediatrics here, but they must have some disaster plan or surge plan in place. I believe within the details of the document, it does say for all patients across all ages, but in this particular slide, it's just generally listed as a disaster plan. Next slide, please. This is where it gets at pediatric patient safety. So they want all patient weights recorded in kilos, not just peds patients, but adults as well, because if you're practicing that with every patient, then it will bleed over to the pediatric patient as well. So that's important. And then they just have other issues related to just kind of the work environment, where there's a place where physicians can eat and drink. Oftentimes, many of you know, those working in the ED, you're just on your feet 12 hours straight and you don't get to take breaks, and so they're trying to create an environment of safety, also making sure that there's not violence against staff, physicians, nurses, etc. Doing some joint drills for any of those sorts of risks. Usually these are called code grays, where there's a combative patient or combative individual in the ED environment. How do they respond to that and address that in a timely and effective way as a team? And then that there be some continuing education, but that it need not be card classes necessarily. Next slide, please. Quality. So one of the other requirements for this accreditation program is that they have some larger quality improvement plan. That includes one, physician oversight for it, but then ongoing reviews, quarterly reports, tracking of measures, documenting ED pediatric readiness at least once every 2 years. So this is important. You'll know that in ACS, they require that participating trauma centers complete the ED pediatric readiness assessment every 3 years. This requires that they complete the pediatric readiness assessment every 2 years. And there are some states, such as Texas, that require that trauma centers complete the pediatric readiness assessment every year. So part of like thinking about this accreditation program is if you were interested in trying to align with this, then for the PEDS recognition, you might also require at least every 2 years. Other quality issues is looking at patient flow and any kind of like treat and release issues. Next slide. Resources. You can kind of read through this, but some of it is having point of care ultrasound for performing quick fast exams or looking for gallstones, things like that. Resources for domestic violence, family violence, translation services, having access to other private areas for breastfeeding and the like. So again, kind of this environment of safety. None of this necessarily is specific to pediatrics, of course, but just so that you have an understanding of what's required. Next slide. So there is a cost for EDs to participate in the ACEP accreditation program, and you can see those listed here. For the rural emergency hospitals and critical access hospitals, it's much less. I think everybody here probably knows about rural emergency hospitals, but these were, the hospitals that were originally, previously, many of them were critical access hospitals, and they weren't able to keep their doors open for financial reasons. And so they shifted to essentially rural emergency hospital, which is almost like a freestanding emergency department in rural settings. But we can maybe talk about that in a future call if people have questions about that designation. It's federal designation. But you can see that in order to participate in this, every 2 years, essentially, this is the cost that EDs would have to pay to be accredited through this program. Next slide. There are currently 7, there may be an 8th pilot site. They just launched this in May, and these sites have been going through the ED accreditation process. I'm sorry, we don't know exactly where Holy Cross is. Maybe some of you do. But these are the states and the hospitals where there's at least one site that's piloting. I think there may be one more that they were looking to add, but we don't have an identified name for that. So if you are one of these states, there's at least one hospital in your state that's using the ED accreditation program. And their hope is that they can push this out broadly, and that because of the integration with pediatric readiness, both in terms of patient safety and weight-based dosing, disaster planning, and then the PEDS readiness assessment, that it will help to align with your programs, your PEDS recognition programs, the ACS verification, and any potential other state regulations or standards in the future. Thanks, Caitlin. So maybe in Florida. Okay. So that's what I know about this program and where we are. And I mean, I'm happy to take any questions, though I may not be able to answer them all, but hopefully this at least provides a little bit of clarity.
Thank you so much, Kate, for helping us circle back to that question and share a little bit more about it. What questions do you guys have maybe for Kate about the accreditation program?
It's Mike, can you hear me?
I can.
So forgive my ignorance. So this is a new program, correct?
Yes, brand new.
And the reason I asked the question, prior to me taking over this role, and I guess it was in the last grant cycle when they were looking at hospitals being designated as opposed to pediatric ready. And there was the trade group here in the Commonwealth vehemently against another designation process. Have you had any inklings of any challenges that there appears yet another designation process that a hospital has to go through? They already do the stroke, they already do trauma, you know, STEMI, whatever else the flavor of the week is. I'm just curious if you've had any input or any communications to that.
No, I mean, so I guess maybe the first piece is just to clarify to everybody the difference between, sorry, and I know you know this, Michael, because you're bringing it up, but just everybody understands the difference
okay.
between accreditation, verification, designation, because they're very different things. So designation is at a state level. A state designates a facility as meeting certain criteria for whatever the standard is. And typically that informs EMS agencies and regions in terms of understanding the capabilities of a hospital or the capabilities that exist within a region. Accreditation is a process by which an external entity will sign off that a hospital or an ED meets certain criteria. That does not mean they're designated. It's just an external entity. The state would have to say, yes, we're going to use these accreditation criteria or this external body to then designate the hospital if they so chose. The other is verification. And the American College of Surgeons provides verification standards, meaning they go on site, they verify whether certain criteria are being met, they check off, and then it's up to the state to decide whether or not they use the American College of Surgeons as the verifying body. There are other verifying bodies for various issues in different states, like the Get With the Guidelines programs has verification programs. So your question is there a plan to create another designation process? I don't know. I mean, I would say that in LA County, they have public authority to designate EDAPs. So those were designated. In Illinois, EDAPs were designated at the state level, and those designations drove EMS traffic to EDs approved for pediatrics. I am not aware, I do not think there is an intent to use the ASAP ED accreditation program to create some kind of designation of EDs. My guess is that there will be many EDs that are unable to participate in this because of financial reasons or, you know, interest or, you know, a variety of other things. And it would be a huge, in my opinion, a huge disservice to communities to say that certain EDs are no longer designated to receive patients. And I think there's a lot of factors that would play into that too, in terms of like Medicaid and Medicare reimbursement and stuff like that. But I am not aware that the ED accreditation program is intending to push for its use in moving towards designation in any regard, because it's general EDs. Hopefully that answers your question.
It does.
Okay.
It does.
Okay.
It also gives me the opportunity to have, I don't want to use the word ammunition, but when the trade group says another, whatever term you say tomato, they say tomato, another level of recognition of some sort that another hospital has to go through. But I appreciate that. I appreciate the explanation.
Thank you for your question. Any other questions for Kate? Well, thank you again for sharing an overview of the ASAP ED accreditation program. If there are any other questions or topics that you would like to discuss further during future sessions, please let us know. You can give me an email. You can send me an email at the collaborative's address or put it in the chat. Today's discussion topic was actually requested by several of you, which makes it especially meaningful as it reflects the interest and the needs of our participants, and we're excited to dive into it together. We'll be exploring how funds can be utilized to support pediatric readiness recognition programs. And the goal is, again, to create a space where you can share insights, ask questions, and learn from each other's experiences. Your input is what drives these conversations, so please feel free to contribute throughout, making this a collaborative and enriching discussion. And to help get us started, you'll see that we have a few questions on the slide just to get things going, but please feel free to share ways in which your program is utilizing funds to support your program, or if you have any specific questions you would like to address today, the floor is yours. Rachel and I are here to help facilitate your conversation, but we hope to enable you all to have this discussion today. I will hand things over to you all. We have Nicolina in the chat. We're using funds to support site visits for mileage, food, etc., and the like recognition plaques, I assume, for after they've been recognized.
Nick, are you using EMSC grant funds for that work?
Yes. So we are using our grant funds specifically, well, I mean, not specifically, one of the ways we're using them is our steering committee for our hospital recognition program. The members will join us at various site visits if they are able to do so in person, and so we cover their expenses as far as food, mileage, housing, so on and so forth. And then we send each facility that gets verified a plaque recognizing that they have been verified under our program and at what level and the date. And so then we can do renewal dates on the plaque.
Awesome. Thanks for sharing.
We're also using a lot of funds to do vital sign cards. That's been super popular. We're going into our 4th batch of ordering this year. We'll probably end up distributing about 10,000. And we mail them out to people. And then as well as we have pediatric assessment triangle posters that we send out. If they want a larger image, they can go to our website and make as many 8.5 by 11s as they want. But we're using our funds to produce some of the larger ones because that's been what seemed out of reach for some of our smaller hospitals that don't have access to print shops in some of the more rural communities.
Is that connected to your recognition program or separate?
Anybody can request them, but specifically it's been going to hospitals in support of their efforts to get recognized. They don't get it if they get recognized. If they don't ever get recognized, they still have access to the resource. But we're trying to make it available to help nudge them along in their work.
I have a question.
Go for it, Mike.
Surprised, I have a question. The amount of monies paid to the consultants, is there some standardized formula or spreadsheet, or is that state to state, program to program, or how do you figure that out?
It's definitely
I
program.
was gonna say we haven't started this yet.
Yeah.
But as I'm developing the basement and the foundation for this to start this process, I need to be able to present what costs are associated and how much. I didn't know what to measure it off of.
Do we have anyone on the call who is utilizing a consultant? And so how you went about that?
Kelly, can you talk to what you have his name just escaped me, but what you have your P liaison do?
Sure. Yeah, can you guys hear me?
Yes.
Had a bunch of audio issues today. We've had an ongoing, essentially just part-time job. But the bulk of it, because we have both EMS and hospital recognition. So the bulk of the part-time, it's done through a contract. I mean, he's not funded through my office. It's a contract. So that covers the person's attendance. I also do the site visits. but travel, attendance, etc. And then because they're contracted, they're available essentially all the time. So they do both EMS and hospital. And the more complicated answer is just government contracting. The other option could do to offer the person like an MOU, but our fiscal prefers us to do it through a part-time contract.
And that contract is funded by your EMSC grant or not?
Yes, in Montana, all I receive is EMSC funds. I receive
Okay.
another funding for the program.
Thanks, that helps.
No problem.
Kate, can you talk to how Sally Snow is funded or was funded? I'm not quite sure if you guys are still using her there.
Yeah, I mean, she was not funded through, well, I think Sam had some funding for her through EMSC to oversee the volunteer pediatric readiness recognition program on the ED side only. I think she was funded at an hourly rate. I don't feel comfortable disclosing that rate publicly here
Oh,
because
yeah.
the particular
All right,
person.
that's quite all right.
But I know that the other way that she's been doing so much of the work in the state was aligned with EMSC, but not directly through EMSC. And it was some funding that was received from a private charitable group. Many of you have probably heard of it already, Toyota Way Forward. And they provided some funding to do simulation work. And that money went to Texas ENA, who then distributed some of that funding to Sally, but also to regional pediatric leads in 18 of the 22 regions in Texas so far. And those individuals are going out to other hospitals in their regions. There are a lot of hospitals in Texas. So we need an army. There's, they're covering 500 hospitals, 18 of them, and trying to go out to those EDs to tell them about the pediatric readiness assessment and get them to start doing some simulation work, and then to join some of the quality collaboratives and the like. But again, that was external funding in alignment with the work that EMSC is doing. What we did in Texas, sorry, I'll just add one more thing. What we did in Texas was we created, launched a Texas Pediatric Readiness Improvement project that included multiple organizations within Texas. So Texas ENA, EMSC, Texas Emergency Physicians, Texas Peds Society, the Governor's EMS and Trauma Advisory Council, the Texas EMS and Trauma Acute Care Foundation, which is the verifying body for trauma centers. And I may be, and PRQI, and all of those together with Texas EMSC have been biting off different pieces of the work, with the hope that all of the participants in any or in all of these programs would eventually go for recognition. But that's just, in a state with 500 hospitals and one person as the program manager, you need an army. So.
Am I hearing, we talk about other programs, generally it's the program manager, director, and one other member of the EMS advisory committee or somebody of that nature. It's not normally like trauma assessments where they send 3 or 4 people or, a herd of folks. Is that generally how folks are doing their reviews and verifications?
We have had the program director, the program manager, the consultant lead for the PEDS recognition program, and typically 2 other individuals at each of the verification visits. And ours have been done virtually, and usually are a several hour visit.
This is Kelly in Montana. So I would add to that, as Rachel knows, we have 18 hospitals or EDs. There's 64. But obviously, basically, except for 2 or 3, all of our site visits require overnight travel. So when the budget, the NOA didn't go through, we were at a stop order for contracts in our whole department. So that also is something to look, not even just how many hospitals you have, but if you have travel, because that's something dependent on funding, we might not be able to sustain. And it's interesting because the goal is to keep increasing the amount of hospitals you verify, but then you're not adding any funding for travel, per diem, et cetera. So we would, the contingency would be to go virtual.
Has anybody else on the call been able to find external funding outside of the MSc program to support any of your pediatric readiness activities?
Not I, but I was just gonna mention Colorado has some similar challenges where everything looks closer than it really is because of mountain passes. And one of the ways that we've been able to work around that is some of our local steering committee members. And we also recruit in hospitals that have been copper verified, which is a model that our state uses. So we recruit people who have gone through our verification process then to participate in some of our site visits. And so then we will try to use someone local to the area to be the in-person representative, and then everyone else is remote. So for example, we have some facilities in the deep southwest corner of the state that it's a full day travel and a full day back. And so we're going to recruit local people to drive the much shorter distance. And then the remainder of us will tune in remotely. So that's helped us defer quite a bit of cost.
And there's no issue with competing hospital organizations?
I'll be real honest, we have somehow managed to foster a really deep connection with all of our facilities, and hospital competition goes out the window. Everyone is just really engaged in supporting each other. We do have conversations with everyone who's going out, and we're working on building a training that says you are potentially going to see things that you would not normally see as someone who is working for a different hospital. And we need you to respect that you may be approaching lines that would talk about confidentiality, but nothing in our program is really unique to any specific hospital. It's just how they choose to get there. And so we have our quote unquote competing children's hospitals in Denver. We have members from each hospital who are participating. And they have reviewed each other's hospitals, and it has always been very respectful. And we have managed to do away with any concerns about hospital competition.
Great.
That may not be in the future, but that's where we're at now.
I appreciate that, and I appreciate y'all letting me ask all these questions.
No, it's good questions, Mike.
I can add to that too, Mike, real quick. A big one too is if it's an ACS verified hospital. So like your bigger hospitals now have to be pediatric ready. So even if they are in competition, it kind of, the critical access and smaller, I kind of would agree with what Nicolina said. I mean, it's about kids, it's about training people on saving children's lives. So it just doesn't tend to be controversial or, a money issue. People just make it happen.
Thank you.
Rachel, I haven't done it, but I am in contact with the foundation at one of our children's hospitals who has identified a lot of smaller grants that she and I are going to have a meeting, and she said that these might be grants that your program could apply for. None of them are very big. Usually they're within the 5,000 to 10,000 range. But that might be helpful for some groups is if you have a hospital that you have a good relationship with who has a foundation that does grant fundraising through grants. she recognizes this program is in benefit to the hospital which she serves, and so does her leadership, and so they've been willing to share that time, but it's not something that I could do on my own because that is her specialty. So that might also be an opportunity for some folks, is to reach out to local hospital foundations and check in and say, you know, if you ever see any grant applications that might be helpful, is there an opportunity to send them my way?
Yeah, that's a great suggestion. What else are people doing out there? Can't just be 3 of you.
In West Virginia, we do site visits. It's usually myself, and our state medical director or our deputy state medical director of pediatrics, and then a nurse that goes along with us. So it's usually a team of 3. We do have some of that state competition of amongst the hospital systems because all of our medical directors are affiliated with WVU, and that is a big hospital system in our state. However, we do not have any issues when we go to site visits. They've always welcomed us with open arms, and the doctors that review the charts with the medical directors as side by side. So there's no, um, you know, of none of that. While they dinged our chart for this, but we give them a reason for everything that anything that there's a ding for, that there's a reason for it and an explanation, and the QI, how to improve it and whatnot. We do a lot of overnight visits. I am very rural from most of our hospitals within the state, from where I sit in my office. So anytime that there is a site visit, I do end up staying overnight somewhere within the state.
So Erin, is the time volunteer and then travel covered by funds?
Yes, so our travel is covered by EMSC funds, and it also covers the travel for our medical director, whichever one of those 2 that goes, and then our trauma department covers the travel for the trauma nurse to go with us.
Awesome, thanks. Anybody else?
Maybe some other areas where funds are being used outside of just the recognition visits. Or is that your entire budget?
What about the application process? Are people using a homegrown application process, or they're buying something off the shelf, or how's that being addressed from a cost standpoint?
Are you asking maybe like paying for a platform? Is that?
Yeah, I saw something recently from a tech group from the Simpsons. Somebody was asking a question about a particular product that they were using. There was a challenge with that, and I didn't know, are most of us using our own application process, or we're using something off the shelf? And I guess is the cost coming out of the grant for that as well? I'm getting kind of granular here, I'm sorry.
In West Virginia, our application is a Word document that they fill out and they submit back to us via email. It's nothing too complex.
I know Oregon uses, oh shoot, name just escaped me. Quick Sheet, is that
Smart
something?
sheets.
Smart, thank you. I'm
I
not
knew
very,
where you were going.
and I'm not very smart. Thank you. Yes, Smart Sheets. And then Caitlin, were you the one that asked the question about Qualtrics?
Yeah, I was. We use Qualtrics for our pre-hospital program. We just finished our pilot phase, and one of the biggest issues that applicants were telling us where it takes a lot of time for them to fill out the application, and there's a lot of attachments we ask for. And so they'll typically complete it in more than one setting. And when they went back to complete their application, their data was lost, which is a big problem because you spend hours on it and then go back to finish it and it's all not there. So on our end, we're able to track their progress, anyone that starts an application, so we can see their attachments, but they can't go back and like finish that same application, if that makes sense. So we haven't found a workaround for that yet. So yeah, still trying to figure that out.
Yeah,
Yeah,
Caitlin, I think
that
it
could
was
be very
your
frustrating.
question I saw.
Yeah, and that was Qualtrics is free access, so we don't have to use funds to pay for it. We get it through our university, so yeah, it's been a great platform aside from that issue.
Looks like a couple folks in the chat are utilizing RedCap. Nicolina shares that comes from Interacts from the university.
Hello, this is Jack. Can you hear me?
Yes, we can, Jackie.
Okay, so we're just starting our pilot program, and in the last 2 grant cycles, we've met with our hospitals and our pre-hospital provider agencies, and so we've been working with them to make sure that they develop the policies that they should have for pediatric care that they don't have. We've been working with them with certification and training, and we've been we gave them like PD mate to make sure that they have safe transport of pediatric patients, thing like the jumpstart triage little badge for each responder. So we've just been working with them to make sure that they can have their stuff to be pediatric ready. We went and did inspection of our ED along with our NICU, and we've made sure that the hospital have the PD crash carts, their Brazil bags, and we just went down making sure that everybody know where they had checklists and they know where everything was, and made sure that they're weighing patient by kilos. And we also helped one of the hospitals, because we have 2 hospitals and 1 big clinic in St. John, but St. John doesn't have a hospital. So most of the patients that's critical on St. John comes over and the EMS Star Life boat to St. Thomas. So we're at that point. We've created a application, and one of the things we send our application to our project manager for review. And so we're working with our Bureau of Information Technology to create an email and our Department of Health link so that we can post our application and they can go on and apply. So that's where we are so far in terms of the nurses in the emergency room territorially wide. Through the grant we've done, the TNCC, the ENPC, and the NRP, and working with them, we've done PALS and peers. So we really push pediatric education and assessment. So that's where we are. And so hopefully when the application go on board, we will have them fill it out. And we want to give credit to, because we've got a lovely pediatric champion, Dr. Anthony Ricketts, and he has private practice, but he has privileges in the hospital, and he's one of our fan members. So when we go out to do any inspection or to talk with them, He comes with me. I'm the project director, our program manager, him and our lead fan member. And that's how we go out when we're doing our assessments. Thank you.
Awesome, Jackie, and congratulations on moving forward with that. It's very exciting. You're gonna get the gold star for the first island to get something launched. So congratulations. Got 5 minutes left. Casey, was there anything for the end or
I have a
this-
few updates, but probably time for one or two more questions if there are any.
Nick, did you see the question in the chat, whether or not you were having any challenges with RedCap?
I mean, I'm challenged by Red Cap, but I wouldn't say I have any challenges with Red Cap. I will say that the thing that's really helped me figure out Red Cap is that I am the assistant to the research coordinator. And my research coordinator really is that's where he lives his life. And so when I have challenges, he's my go-to guy. So I just, I have found somebody who really knows what this is. CU is also very supportive in that they have a couple of staff members who are dedicated specifically to Red Cap. And so if you have a question, usually I get a turnaround in about 30 minutes. But I mean, if there is one of the challenges we have right now is that we have to manually request policies to be reviewed in advance. And so we're looking at doing a potential checklist update in November. And at that point, we're going to try to see if we can get hospitals to upload policies into there. That is where hospital competition really comes into play, is a lot of our facilities have said, you can look at our policies, but you cannot have a copy of our policies. And some of that is security, right? Like you don't want bad actors getting access to an emergency management plan that might tell you how they're going to respond to something, but some of it is specifically competition. So part of what the state does, and our process is mirrored off our state's trauma program, is they have a secure repository, and Red Cap is very secure. So that might be something that we are looking for towards the future. But right now, our process for requesting policies is pretty clunky. Caitlin, if you have specific issues with Red Cap, let me know. Once it is a lift to get it up and running. Once it's up and running, it's really pretty beautiful.
Awesome, thank you.
I appreciate it.
And that Red Cap there's a big learning curve. One thing that I think is also super handy is, if there's someone who has a Red Cap application that you're really like, oh, I like that, and they're willing to share with you the data dictionary, you're able to easily take some of those pieces and add that to your project.
Which we have and are and will. So if anybody wants my contact information, it's in the chat.
Yeah. I find that very handy for the projects that I work on in Red Cap as well. All right. Thank you all for today's discussion. If there are any resources that you're finding very helpful, please share them with us and we can add them to the State Partnership Program Manager Library so that you all have access to them. Thank you again to those who provided topic suggestions. We look forward to addressing some of those during the October session. So we'll be meeting again October 16th and then November 20th, where we'll hear updates from you all again. As a reminder, here's a list of the states or territories that have been invited to share an update in November. Please let me know if that date doesn't work for you. A couple next steps. This week, I will be emailing a survey to EMSC State Partnership Program Managers, an invitation to complete a 2025 PRRP survey. It's an opportunity to share updates on your recognition program with our exchange team, as well as a place to provide input on what you would think would be beneficial for us to focus on in the coming months. So please keep an eye out for that invitation and take a few minutes to complete that survey. And then we'll meet again in October and November. That is all we had for you today. If you do have any additional questions, feel free to put them in the chat or come off mute and let us know. But thank you all for joining today. We hope you have a great rest of your day.
Hey Casey, I have a question for you when you're ready.